Thanks for tuning in to another episode of Watson Clinic Health Talk. Cancer is a diagnosis that no one wants to hear, but the latest advancements in surgical techniques are bringing hope to countless patients who are embarking on their own cancer journeys. Our guest on this episode stands at the forefront of those innovations. He's Dr. Dany Barrak, a board-certified general surgeon and surgical oncologist who accepts appointments from our Watson Clinic main location in Lakeland. In this conversation, Dr. Barrak discusses two groundbreaking procedures he recently introduced to our community: the miraculous benefits of robotic-assisted surgery and the role that genetic research plays in shaping the future of personalized cancer care. For more information and to schedule an appointment with Dr. Barrak, call 863-680-7486 or visit watsonclinic.com/Barrak. That's Barrak. You're a general surgeon and surgical oncologist.
Correct.
Could you give me a sense of some of the most common conditions that you treat in that capacity?
Absolutely. So, yes, by training, I am a general surgeon. That means I used to tell patients that we usually cover everything from the neck down. And by that, I mean, a lot of endocrine involved, the thyroid, the parathyroids, a lot of the soft tissue stuff, skin, muscle, things like that. And everything intra-abdominal. General surgery involves a lot of the, elective practice, non-cancer practice, and a lot of the acute surgery, so all the emergency surgeries that need to happen in the abdomen. When we say surgical oncology, it's more of a focus on the complex cancer world of the general surgery, and by that, when the tumors involving, the liver, the pancreas, the stomach, small or large intestine, when these are involved, it becomes more of a challenge. So that's why, to become a surgical oncologist and to treat these things, you have to, undergo a little bit more training, and it has its also board certification by itself. So, you tend to cover just that. So it's kind of like a subspecialty of general surgery.
Yeah. And you're board certified in both general surgery and complex surgical oncology.
Yeah. So you have to be board certified in general surgery as your first approach into the kind of certifications in the field of surgery. And then, yes, because it's also this subspecialty is certified by the American Board of Surgery. So in order to be a board certified surgical oncologist, you have to sit for the same, exam. And once you've kind of passed through all the steps and the certifications, you will be, a diplomat of the surgical oncology board as well.
So typically, when do people come to you for counsel, or is it through referral and they meet you at your office? Or?
Yes. So mainly just because we are a subspecialty, we usually have patients come to us already with a diagnosis. That means they've already been worked up by their primary care physician, or they were at the hospital and they saw something worrisome on CAT scan, so they send them to us. Because sometimes, we have our own sub-specialized workup that we know about just because this is, what we do. But we do also just get patients with some symptoms that really kind of no one can explain. And then, we'll use our experience and some extra, diagnostic tests to make the diagnosis ourselves and treat it. But the majority are, yes, a direct referral after they already have a diagnosis of cancer.
And sometimes does that originate in the hospital in an emergency situation?
Yes. Sometimes, even unfortunately, patients with cancer still do get some emergencies. There's a good and dedicated team at the hospital that takes care of them in the acute setting or in the emergency setting, and then once they're stable, they can either consult us and we'll be happy to see them in the hospital, or when they're recovered, they get sent to us and we'll see them in clinic. So we do see both inpatient and outpatient consults.
You talk about how the field of surgical oncology is evolving quickly, and I'm wondering, just in the time that you've been a part of this practice, what kind of innovations have excited you most?
I have a big interest in minimally invasive surgery. That's kind of one modality of surgical oncology that I'm really interested in. Robotics now and laparoscopic surgery right before that really changed how we treat cancer related surgeries, to a point where some type of cancers now, the gold standard is minimally invasive surgery. So, robotics pushes that limit a little bit further. Cases that we were not able to do in the past, either even open surgery or even laparoscopic, now with the help of the robot, we're able to achieve that. And it's very important because cancer related treatment is really a multimodal treatment approach, and by that I mean there's a lot of different teams involved. As we know, chemotherapy, radiation therapy, all the things are very, very important, but ultimately in the majority of cancers you really want to get the tumor out. So I think that's really the end or the goal of the major outcomes from cancer related disease. So if you're able to take the tumor out, that affects the patient's life, and that has survival benefit in most of the situations. So to be able to get tumors out using the robot that we were not able to remove before is really kind of making a lot of headway and pushing the surgery to the limits.
So the reason why you weren't able to reach the tumor before and now you can with robotics, explain that to me.
Yeah, no, it's a good question. So we have limited articulation of the arms, and sometimes when we're working in the pelvis, it's a kind of a very tight space, and you're not really able to maneuver both your arms and as well as kind of see, because we have to see where we are in order to do the surgery. So the robot has an HD camera, and it has 7 degrees of freedom, longer arms. They're smaller, they're tinier, they're more meticulous. As much as we try to stay still while doing surgery, sometimes you really can't help a little bit of tremor, which we all have to some degree. The robot kind of emits that. So the robot kind of parallels your arm movements, just minus the tremor, especially if we're working around major vessels and nerves that if you injure them, it's kind of a problem. So that's where the robot really becomes handy. The other really important thing is the robot can assess perfusion. Sometimes when we do surgery and we cut out part of the intestine, let's say, it'll be difficult for us using our own eyes to tell if the remainder of the colon, for example, is viable. So there's this technology within the robot called ICG, or indocyanine green. That gets translated into it's a dye that gets infused into the patient's veins, that the robotic camera can actually read it and analyze it and see if that dye gets into the area where you did surgery. It just gives us a sign that it is well perfused, so it gives us a better idea if we can work further or kind of reconnect the colon without having to worry about like poor perfusion or oxygenation. So these things together can really help push again the robotic surgery to higher limits.
Yeah, it really has been a game changer. I know our surgeons for years have been using it for
Correct.
hysterectomies and all kinds of things, but I think it's important to accentuate this, that it's not a robot that's programmed to work on its own. You are in control of the robotic arms at all times.
I'm glad you brought this up, because when I explain, or when we run through the procedure with the patient, and when we go over the consent, I always tell them, this is a robotic. I don't like to call it robotic surgery. I think I've mentioned that to you before, but I like to call it robotic-assisted surgery, because the robot cannot do anything without the surgeon. We're in control of everything, the camera, all the instruments. Any small move is done by the surgeon. The robot cannot do anything. It just translates our hand movements into what we call the patient cart or the part of the robot that just sits next to the operating room table. So it's just a matter of translating these instruments. And safety comes first. The robot also is a technology, and we know, just like us, everyone's prone to error. But the good thing about it is we can always disconnect the robot at any point during any emergency. And this all the operating room staff, as well as all the surgeons there, we're all trained to kind of disconnect the robot. Literally within seconds, the robot can be out of the way, and we're next to the patient, handling whatever the problem is. So I think that's also very important, and I usually let the patient, know that it's not that no matter what happens, the robot has to continue the operation. We can get control back and be back, on the operating room table within seconds.
Yeah. I want to talk about a couple of procedures specifically that you've performed recently. And they're very noteworthy because it's the first time these procedures have been performed in this community. Why don't we start with your use of robotics in the carcinoma removal that
Correct.
you did a few months back?
Yes. So that was a very interesting case. And we're very happy that we were able to achieve it. It's the first, we did a couple of them, and they were the first few cases done in the region. So we kind of touched base a bit, on this, which is rectal cancer. So the rectum kind of lies in the pelvis. It's a very narrow field for operation, and patients with large tumors, getting down there can be very, very challenging. Rectal surgery is morbid. That means carries a lot of risk, as well as possible complications for patients who really need to recover as soon as they can, or as soon as possible, so that they can get back on treatment. So you really want to take the tumor out and get them to recover as soon as possible. So we have pioneered here, and again, I mentioned this in the past. I teamed up with a very good colorectal surgeon from the hospital, Dr. Rashid, and we worked on something called a robotic transanal resection of tumors. So again, we're using that same technology, but instead of doing a lot of incisions and accessing the abdomen of the patient and going through all the risks and the possible complications, by doing that, we will actually use the long robotic arms to do transanal surgery. And by that, we go in, we're able to resect the tumor fully, close down the defect at the site where the tumor was, and then there's actually no scar. The patient, walks out of the operation, goes, back home within hours, and, the tumor is out. Now, definitely this has certain characteristics and certain requirements to be able to do that, but that really, again, pushed the limits of the robotic surgery to like standards we've really never seen before. And I think that's very, very good. So I really want patients to know that we do treat all stages, early stages, or even more advanced stages of rectal cancer here at Watson Clinic, and they can consult with us, and we'll be happy to take care of it, because we really do. We're fortunate enough to really have all the modalities to treating such malignancies. So
it was a rectal tumor that you were able to remove, and you also had to remove a little bit of surrounding area. What's
Correct.
that
That's interesting. So yes, there's this concept in surgery which is called margins. You really want, when you take out the tumor, you don't just want to take out the tumor itself. You want to take a little bit of some healthy tissue around it, because you want to guarantee that even under the microscope, when the pathologist looks at it, that the entire tumor is out. Because if you leave some small cancer cells behind, these cancer cells, they love the blood supply, and if there's still some blood supply, they're going to unfortunately grow again. So for you to minimize that from happening, you want to go ahead and remove a little bit of that healthy tissue where some of those cancer cells might already be. That way you minimize the risk of this cancer coming back. So yes, we're able to do that as well through the robot.
Yeah, it's amazing that just the precision and the minimally invasive approach that
Correct.
you could,
like, that's the most minimally invasive you can get.
Yeah, in an area previously that would have been
correct,
almost
impossible
invasive.
to work.
Yeah. So before we get into the other procedure that you've performed recently, in terms of the physicians and the departments and locations that you most commonly work with, I would imagine the Watson Clinic Cancer and Research Center refers a lot of patients your way as well.
Yes, exactly. Because, what we're trying to build, and I think we're doing a great job so far, is to really build a comprehensive cancer care clinic or institute for Watson Clinic. And I think we do have all that it takes to really, take care of the most complex cancer cases.
I'm sorry, I just want to go back and reiterate something about the previous case you talked about.
Yeah.
It's amazing to me that the patient also went back home that same day.
Yes, exactly. So that's these patients with rectal cancer, I usually tell them at least 3 to 4 nights in the hospital. That's kind of, what the time they need to recover in terms of pain control, them being able to eat again, walking around, because it's painful. Even though it's minimally invasive, it's less painful than, the bigger surgeries, but still it's very painful. When you do surgeries like this transanally or through the anal canal, then there's not much nerve fibers there. And the pain that's associated with it and the delay in you being able to feed them and start them back on their diet kind of delays things and, prolongs their hospital stay. So by doing that, you're really able to, I tell patients, when they ask me like, oh, what do we expect? It's honestly just like finishing your screening colonoscopy. Like it's almost just, similar to that. So, they get to stay, a while in the recovery unit and just go home in a few hours.
Goodness.
Yeah.
That's just remarkable.
Yeah.
So the second case that you performed recently involves an abdominal cancer removal and an unusual form of distributing chemotherapy to the affected region. I'm wondering if you could expand on that.
Absolutely. This is also another area of interest that we recently also adopted here at the Watson Clinic. So the term stage 4 usually scares patients a lot because that means it's end stage. There's nothing more to do, and we're done and we're giving up. So this approach really gives hope to patients with what we call peritoneal carcinomatosis. That means when the cancer has spread not to the entire body, but if it originated from the abdomen and it has spread to neighboring structures within the abdomen. That's the terminology called peritoneum. Peritoneum is the inner lining of the abdomen. So peritoneal carcinomatosis, it means that the tumor had spread, but it really didn't go outside of the abdominal cavity, and we see that in a lot of cancers. This in the past used to also be treated with just giving them, cytotoxic drugs or chemotherapy. And chemotherapy, as we all know, has a lot of side effects. It kills those, rapidly growing cancer cells, but it also kills all the normal cells. That's why patients have all these, complications and side effects from chemotherapy. So what we're offering now is something called HIPEC, or hyperthermic intraperitoneal chemotherapy. That's been studied very, very well. It's a procedure where instead of giving the chemotherapy through the veins and where they go through the entire body and have all these effects on the lungs, the heart, the hair, the intestine, we give heated type of chemotherapy inside the abdomen for around 90 minutes, and that has almost the same effect on these cancer cells within the abdomen as giving it through the vein, minus all the potential side effects. That's a very kind of subspecialized approach, and again, I want to highlight the importance of collaboration here, because we started the first procedure that was done on a Watson Clinic patient with the help of the Lakeland Regional also Surgical Oncology Department, Dr. Coach. So we together did this procedure, and the patient actually did very well. There were no sign of disease recurrence or any sign of residual disease after we finished this procedure. And the patient doesn't need to go on chemotherapy.
Wow.
So this is a very, very important thing that was not offered in the past, but now we're offering it at Watson Clinic, and I think that's also very promising and highlights the importance of us being really comprehensive and trying to treat all different types and all different stages of cancer.
Oh, that's remarkable. So it starts with the tumor removal.
Yes, absolutely.
And then that's when you insert the chemotherapy into that region.
Correct. So, it's the right, terminology that we use and we try to explain to patients. It's something called cytoreduction and HIPEC. So cytoreduction means, like you said, removing the tumor, trying to remove all the larger, I would say, tumors within the abdomen, because these ones don't usually respond very well to chemotherapy. But again, the tumors that worry us, or the tumors that really cause a lot of harm, is the ones that we cannot see, and these are the ones that are going to spread outside of the abdomen. So that's when the other part of this procedure, which is called the HIPEC, that we recently added to to our services here, is the HIPEC, where that chemotherapy, just we let it circulate for 60 to 90 minutes within the abdomen, and that's when it really, because it's heated, and it's because it's a special type of chemotherapy, it's able to destroy and kill the residual tumor cells that were potentially at high risk of spreading what we call extraperitoneally, or outside the abdominal cavity.
Yeah, so the heated allows it to absorb.
Correct.
Yeah.
It's been studied, that once you heat it, you allow the body, or what we refer to as the heat shock proteins, to come into play, and then absorb that chemotherapy into the cells of the peritoneum, into the all the organs, and that's how these tumor cells get killed.
Have you noticed improved survival rates based on these new technologies and minimally invasive approaches that we've been discussing?
Yeah, that's a great question. That's always a question of interest to even in the medical field, and also in the community. The short answer is yes. There's survival and outcome in the medical field that has a lot of kind of subdivisions. There's what we call overall survival. That means, does the patient actually going to live longer, or are they going to just live longer without this kind of disease, or what we call recurrence-free survival. So in the majority of the cases, again, in well-selected patients and subtypes of tumors, because we know there's hundreds of different types of cancers, yes, they do affect the survival, and that's kind of what we look for. There's what we call statistical significance. That means on papers or in studies, it shows that it's better. But there's also something called clinical significance. That means we don't want just the numbers to look better. We want patients to do better. So these procedures are a little bit new. So I would say the numbers are looking promising, and I would think that they would eventually have both statistical and clinical significance.
And what are you most excited about in the near future in terms of different approaches that are coming around the corner?
The idea that we used to think of cancer as being treated, one drug for all, and we do the same thing no matter what it is, no matter what stage. And with time, we're able to prove that we now have this concept of personalized cancer care. That means, with all the advancements in genetics and what we call molecular profiling, we're really able to understand how these tumors behave, and how they function, and what's their subtype like. Do they like to metastasize or spread? Do they have a high chance of coming back? So I think what I'm excited about is seeing this personalized care being more and more advanced, because we're starting to take every case separately, instead of just kind of putting all the colon cancers together and treating them the same way. We go patient by patient. Every patient's tumor behaves differently. Every body's immune system behaves differently. So now we have all this data that can help us really dictate how to treat these patients. If we learn more information, I'll just give a simple example about, let's say rectal cancer. Based on the profile of the tumor and the patient characteristics, we can now decide, well, this patient will probably do better with surgery first and then giving chemotherapy after, or let's start by giving radiation first, because that's how the tumor will likely respond, and then doing surgery after, and things like that. So the concept of personalized cancer care is really what I'm interested to see.
And that all comes from this genetic data and all the research to know how they're going to respond.
Correct. So we we refer to it as the molecular profile, or just genetic profile of the tumor. We have all these genetic data banks that now have a lot of sequencing of the almost all the human genetic components, but also of like tumors. So we can compare them and see how they behave based on what genetic profile they have.
Okay. Yeah, that is incredibly exciting.
Yeah, it is very interesting.
So that's an ongoing kind of the more data that we collect, the more advanced our approaches can be. And so it's ongoing.
Yes, exactly. It's definitely still ongoing. There's still a lot of work to be done, but now there's the idea of targeted therapy and immunotherapy and things like that that are not. They're more effective and not as cytotoxic or damaging to the patient during this process.
You have surgeries today?
Yeah.
I can see that you're looking at your watch. You're like, I gotta get.
No.
So I won't keep you. Just one more question for you.
Please, no, I'm happy to be here.
What do you love most about what you do?
Wow, no, that's a question that needs a lot of time. But I'll try to summarize it. And again, this is something I face and I try to answer every day. People think that once they get diagnosed with cancer, that's the finish line. That's something that's going to change their entire life, and they don't see much future. What I love about what we do is us being able to give hope, because in the majority, I would say, and I'm confident to say that in majority of the cases now, we make patients feel better. We get rid of their tumor burden, their cancer burden. And, with proper care, we're able to make them live longer, be with their loved ones and all that. So I think, to me, that's just unmatched in terms of the, satisfaction it gives you when you're able to give that to your patients. I come to work every day trying to see, how much I can do to really, change that, mentality or that stereotype about, just being diagnosed with cancer. So,
yeah, that's wonderful. And I'm sure you see the emotional journey
from
the moment they walk in your office.
Absolutely, especially in the most complex patients, when we see them before the surgery, then right after surgery when they're, in pain and it's still kind of a bumpy road of recovery. And then, when they start getting better and the family is involved and you're seeing them every day. I mean, these patients are family. So, it's pretty an emotional journey.
Well, thank you so much, Dr. Barrak, for being here.
It's my pleasure. I'm happy to be here.
That's it for this episode of Watson Clinic Health Talk. For more information and to schedule an appointment with Dr. Barrak, call 863-680-7486 or visit watsonclinic.com/Barrak. Don't forget to subscribe to our show wherever you get your podcasts, and leave us a positive review if you like what you hear. Visit watsonclinic.com/podcast to learn more. Till next time, thanks for listening.